I am with Professor Dr. Carlo Di Mario, and today is World Heart Day. And we find it's a coincidence that in 2019, also in San Francisco, I was with Dr. Mario, and that was a chance that it was in TCT, and we had a word with him and face to face with Dr. Mario.
Hello.
Dr. Mario, Carlo Di Mario is a very famous, eminent cardiologist, earlier in UK, now in Italy, a personal friend since 2008. When we did the second Indo-European conference and conclave in Bharati Vidya Bhavan in London. At that time he was one of the course directors, and I still have a relationship, personally, friendship now with him. Today we are on celebrating One Heart Day at the Interface SCAI conference, which is Society of Cardiac Angiography and Interventions, which has just finished the 2 days of conclave talking about various aspects of interventional cardiology. So now I would like Dr. Carlo Di Mario to a little speak about himself and then give a small message for interventional cardiologists and public at large in India. When he's visiting India, it's not easy to get him. So now over to Dr. Carlo Di Mario.
Well, thank you for having me here. It's true, since I traveled quite extensively and I moved from hospital to hospital, that was a time in my career that I had to cut my international traveling, and India has been one of, unfortunately, the country where I couldn't come for almost 10 years. I'm amazed to see how much progress has been made by Indian interventional cardiology in the meantime. Not only the country has changed dramatically, but also availability of material techniques, quality of the interventional work has become very similar to what is now the standard around the world. The other difference that I notice is that now there are many prominent Indian companies that will become good competitors of the classical US-based catheter companies, and both in the field of coronary and structural work manufacture products that have little to envy compared with the products that I tended to use in the past. So, thank you for having me here.
Okay, Carlo, quick two questions only, because we all have finished from this work. One is that what do you see is the further future of TAVI, which is now established for last almost 22 years, when the first case was done by my mentor and guru and personal friend, Dr. Alan Previer, on 16th April 2002. And I would like to remind the young people who are not aware of this, that it was very hard work for him. Since 1994, he was trying to find a sponsor, and this was completely refused by Medtronic and Edwards, which are now flourishing with selling these valve now. 1999, he made a company with Martin Leon, and I think Dr. Carlo Di Mario must have been involved somewhere, because he was in UK at that time. He made a company, PVT, and then they made from Israel, they made a prototype, and then they used it in animal experimentation, and then it was done for the first time in a human being on 16th April 2002. After that, more than 6 million cases worldwide have been done through it, and life-saving procedure in severe aortic stenosis. So, Carlo, I just wanted to know, we met in 2008 in London. At that time, I think the UK started having the first TAVI case in 2008 only. I was told by Bernard Pendergast last 2 weeks back. And so you were involved from the beginning at that time in UK, and what was your contribution, must have been, in this development of this technique in United Kingdom at that time, or Europe as such?
Yeah, well, you mentioned that you have been one of the fellows of the inventor of the technique, Alain Cribier, and we also tried to have him coming to our hospital, to the Bronto, for a palliative case. In 2004, I remember correspondence was very difficult for regulatory reasons, and at the end of the day, we started, in fact, with the Medtronic, with the competition in around 2007. I confess in London my main task was on the mitral side, so mitral clips. I was involved in TAVI as well, but it was only when I went back to Italy in 2016 that I started to work in a center doing really a very large volume. Right now we do almost 350 cases per year, and we are using a combination of balloon expandable, predominantly 60%, and the remaining two of the other types of sacral expanding. We are using the accurate neo from Boston and the Evolut FX from Medtronic. I mean, contribution is difficult to contribute more than the heroes of this technique, like Martin Leon primarily, who did the trial that have shown us how important, how effective these devices are. A little maybe added value was the ability, since I was one of the first shockwave investigators in the coronary and I had some peripheral experience as well. I was the first to apply intravascular peripheral lithotripsy in the preparation of iliac vessels to the delivery of these large devices, and I must say this has dramatically changed our practice. We hardly ever use alternative accesses, occasionally axillary, but is around 3% of cases, and transapical has almost disappeared.
Yeah, one last question. I mean, you know that you are master of CTOs and coronary artery disease. Do you ever see, because now in India especially, the number of cases of coronary artery disease, heart attacks, atherosclerosis is growing. I mean, do you ever see we'll have something which will actually dampen or reduce the herald, the process of CAD? I mean, the CAD which is going up. In Europe, I think it is static. The number of cases which were there, I mean, the incidence and prevalence of this coronary artery disease is almost static. In India, it's exponentially rising. Do you hope that in the future, especially for the World Heart Day, what the public should do so that the rise of CAD deaths should be reduced at least to some extent?
I mean, you are perfectly right. I mean, I started at the time when having a couple of STEMIs at night was normal, and we didn't have much more than lytics intravenously to be given to selected patients, often with awful complications, and now that primary angioplasty has become so effective, well, it's almost a pity that we don't use it as often as before. We are one of the busiest centers in my city, but still we are doing less than 200 cases a year of primary angioplasty for ST elevation myocardial infarction. Non-ST elevation is still a fair amount. CCS we tend to use a bit more of proper medical treatment than in the past, but I confess overall you are right, numbers tend to come to a limit. I think the main reason why they don't go down completely is that population aging is such that you have patients in their late 80s or 90s already developing coronary artery disease, very difficult to treat, highly calcified, very tortuous arteries, very diffuse access. These is the challenge for Europe. I guess you will follow soon when people understand that they have to stop smoking. The statins are not an enemy but a friend, and has to be used liberally. And when we will have these new very powerful injectable or less lipid lowering agents, GLP-1 receptor agonists that make everybody slimmer and hopefully with normalized glucose and metabolism, I guess that there will be a major change in the incidence of coronary artery disease.
Oh, that's a very valid point. I mean, that we need to use more and more of these new agents so that we can have less number of coronary artery disease. Very quick last question. I mean, this is coming to my mind. You have a lot of sudden deaths. In fact, we lost Alan Crevier in sudden death. The defibrillator was not there. I mean, the guidelines say, my personal view, guidelines say we lost another one of my relatives yesterday in the sleep. He was having ejection fraction, which was not so bad. So the guidelines say less than 35, do AICD. Otherwise, don't do AICD. But we know that necrotic myocardium, even with ejection fraction of 40%, can also throw ectopics. Do you think that we need to change the guidelines? Because as I remember, I have lost many of my patients who were not classical indication for AICD. Do we need to revise the guidelines so that more number of patients can be benefited by the device like AICD and we can have reduction in deaths? I personally feel that something has to be done because of the guidelines we are not able to deploy this implant the AICD and patients are lost.
I think you are right. Guidelines like to make everything simple and stupid, which is good because, of course, if you have to be followed, you must remember them, and it should be easy to apply. However, for any indication to ICD is not so simple. Even cardiomyopathies, you have some cardiomyopathy with some genetic predispositions to arrhythmias, where a 40-45% ejection fraction, I would love to see an ICD implanted early. And the same is true for patients with extensive gadolinium late enhancement, so large fibrotic areas, because those patients won't recover. There is no point to wait 3 months after revascularization for acute myocardial infarction. That's the time where the people die, and a live vest is not an efficient, besides the cost, modality to avoid that. I think early implantation, sometimes in younger individuals, subcutaneous ICD, they work very well. If they don't need pacing, that's fine. I think it's better to go earlier than later, and we have to remind ourselves we are not just interventional cardiologists, we are cardiologists in following all fields of our profession, and our patients need all the cardiology expertise.
Thank you very much, Carlo. You have taken my heart, because this was something which was pressing in my mind, that why we cannot do AICD in an ejection fraction little more than 35, and who is likely to throw ectopic and he will die, and then there is no point. I mean, you lose the patients. Thank you very much. It was wonderful talking to you, Dr. Carlo Di Mario, my personal friend, and we hope that you will be part of our IECR again, which will be on 30th November in Delhi, but of course you may not be able to come, but you can virtually join. And also we are doing on 26th, 27th December in Port Blair, which is Andaman Nicobar in the Indian Ocean. So we will like your presence, although it will be Christmas period vacation, or we can have a recorded talk. Thank you, Carlo, for coming to India, and I would love, as Ella Crevier came to my house in Delhi for a dinner, I would love your presence for a dinner in my Delhi residence whenever you come next. Thank you so much.
Vivek will happen.
Thank you.